just Brady, I was just reading what you had put there, and so without getting into this, so Judy will go into this in more detail, but my understanding would be that, or what my intention was, is that there would not be, so for those, that I would record those lectures, which would allow you guys to have more flexibility of um, when you would review them, and so that you wouldn't be locked into the Saturday and Sunday. Um, this is my understanding, but again, and I know Judy has been working diligently with regard to this, but the what I was perceiving, and again, she will discuss this tomorrow, is that my interpretation would be that I would be um, that it would, that I would make those lectures available so that you could look at them and you weren't locked in. I could be wrong, but that's the way I was understanding it. Second thing is that there is the issue of if there's questions, and I know Judy and I had a brief conversation, and she's really trying to work things out. But the other thing was that there would be times where that I would be available online so that we could go over those questions, to do, so that you could have some interaction with those. So, but again, she will go into that tomorrow with regard to it. And so the things that you guys have, are your questions and concerns that you have is, um, I think she wants to, have that discussion with you guys tomorrow. But again, we're one of the things was because of the back-to-back things, and one that have occurred was to just try to give you where you would have. Again, my feeling was is I would have these lectures available. I would tape these lectures ahead of time so that you guys could look at them. But at the same time, both Judy and I felt like there should be time when um, there could be interaction there, and again, the taped lectures were just going to be a couple of them. So that was that. But again, she will go into that in more detail tomorrow, and I think answer some of the questions that you guys have had. And I do appreciate that you've already sent her emails so that she can be thinking about that. Um, so anyway, again, the idea was, as I understood it, is that the lectures, I was planning on doing the lectures and having them available ahead of time, but also making sure that there would be times when we would have could interact, and that may be, a couple of 2 or 3 sessions. It may be that not everybody was there, or that we could accommodate that somehow. You guys always will have access. I hope you guys know that, with me, that you can send me an email, and a couple of you sometimes have called to go over some issues, and I think that is there. And that, but anyway, I think Judy will go through and I think be able to clear up some of the issues there. And um, so that's just to give you a heads up. Um, of course, I can use this as a teaching thing because we're talking about, stress and anxiety. So, we can see how you guys are doing that. So, but anyway, that's one of the reasons why Judy wanted to talk with you guys tomorrow. And so at the end of, or I think she's going to come on at 12:45 tomorrow is what we've got her scheduled with, and use some of the time to do that. We'll still be able to cover the material, I think, without any problem. And we'll go with, I'll work with whatever we can to try to, to do that. You guys know that, we're, and I really think that Judy and I and the rest of us are wanting to, we know this is a stressful course and everything, and again, stressful curriculum, and so we're trying to work this out. Some of the things I think have been put on with regard to Alliance. So anyway, there will be some discussion, but Rebecca, you might bring that up with regard to some of these other issues there too. Okay, but I would, for definitely sort of the concerns you have, is I would have those questions available so that you can make sure they get answered. And again, I think Judy will do that so that there is I mean, Judy will take the time to try to go through everything. I found her very easy to work with. I've enjoyed working with her. Okay. And we know, and Brady, we do know it's not that you guys are complaining about that you're not trying to, um, that you're not trying to, we don't see you as trying to look for an easy way out. That has never been a situation where that we've even thought about that or even perceived that. And I have in the past, and many years ago with another university, have seen that the students were just trying to find the easy way out. But I think that's not ever, I mean, that's not a situation which we're looking at all. Okay. Okay. All right, guys. Let's go ahead and, Eddie, let me just address the online activity. Basically, what this is going to be, the online activity, and Judy will verify this tomorrow when she talks to you, but the online activity, first of all, I will tell you, most internet programs have now required this. What I look at online activity is basically there would be similar to what you guys had before. Is I would either send you a short video or something like that where you would have to log in on Moodle just to and answer a couple of 2 or 3 questions there. But we'll let Judy discuss all of that tomorrow from a standpoint of trying to address those things. Okay. All right. And
I apologize, Doctor. Are we gonna go and review the quiz that we just had before the
yes,
break?
I'm just getting ready to go through that. So I'm going to read the question and then give you the answers. These questions should have been pretty straightforward from a standpoint of I've got another computer up that I've got the quizzes on, so I'm gonna pull it over here. And give me just a second. Okay, so the first question was mitral valvulopathy often is a comorbid condition with, this should have been pretty straightforward with regard to, since we had just covered it. So the answers are agoraphobia, B, panic disorder, C, increased parasympathetic nervous system activity, and D, none of the above. So the correct answer is B, panic disorder. Realize that the mitral valvulopathy creates conditions very similar to panic disorder. Remember, we talked about many times it could be comorbid. Agoraphobia can be sometimes comorbid with panic disorder, and it actually has increased sympathetic nervous system activity. So the correct answer is B as in boy, panic disorder. The second question is anxiety disorders are associated with either A, increased SNS activity, or B, decreased SNS activity. Aiden, thank you for putting that up. And the correct answer, as we've talked a lot about this morning, was the fact that anxiety disorder is heightened activity of the sympathetic nervous system. So the correct answer is A. And then B, 3, anxiety is always associated with decreased performance. And the correct answer, this might, as I look back at it, this may not have been the best worded question, but the correct answer that I was thinking on this one is B, false. And that gets back to the anxiety can improve in performance for a while, up to a point, and then it becomes detrimental. So the key word here is always associated with that. And so since it says as always, the correct answer would be false. Okay. All right. So the next sets of questions that I'm going to give you will be a little bit more challenging. The one I give you this afternoon and the 2 tomorrow. So, but again, just to get you thinking with regard to these type of questions. And again, I'm hoping that by tomorrow we'll have time to do a couple of cases with working a couple of cases that I've got in mind here. Okay. And I have not forgot about the CRF. I had an article that I was was thinking about having posted on Moodle. But there may be another article, if I can get that article maybe a little better. So we'll probably post that up from there. Okay. All right. So let's see if I can move on. And we had just started talking about post-traumatic stress disorder. That was where I stopped because it was a good stop here. And I am going to give you a couple of the clinical trials papers for you guys to read for tonight that my student reported on, where that prazosin and ketamine had been used. So these are a couple of recent papers where they were doing clinical trials, and we may have a little bit of discussion about those in the morning. So that would be something that I would give you, for tonight to maybe look over. All right. So PTSD is basically post-traumatic stress disorder. It is considered a chronic illness. And most people, if you talk to them about PTSD, I think most people generally know what PTSD is. One of the things that we see is that PTSD, one of the things that I've seen recently from a standpoint, just a minute, let's see, let me address Gupta's. Gupta, you were talking about stellate ganglion blocks for, I assume, treatment with regard to, for PTSD. The stellate ganglia, with regard to that, is if you look at stellate, because they've done some stellate ganglia blocking for some other things, and the problem is, and I think actually, Eddie, you've hit the key point, is there's been inconsistent results on that. And in fact, with a lot of PTSD treatments, with a lot of different ones, you've seen that there has been issues there. We've also seen people using these for excessive autonomic activity on other conditions, and there has been some inconsistent results with those also. Yeah, and that's the thing with the media, is because PTSD is such a big issue. I get calls with things like different things all the time, and what they will see is that somebody may make a big what you find with the media a lot of times is they will jump on where it looks like something may be somewhat successful, and in reality they don't do a follow-up, or that it's been a small study or something like that. And so it's a very I get called by journalism all the time for their students on issues, and the point is that it's a little bit sensationalism there too. And what you find is that basically you will have some. It's like sometimes with doing cortisone injections into to joints that are inflamed. As one of my friends who is an orthopedic, he said probably that works in about 1 out of 10 people really well, but it works so well in that one person that everybody wants it. So it's been a big issue there, and there is some big concerns with regard to it, because everybody wants, for a lot of these chronic diseases, especially like PTSD, they always want this this miraculous treatment. And so again, when you're doing long-term follow-ups, Eddie, as you've been talking about there, is that the thing is there's a lot of almost bias that you hope it works. So and you're going to see a lot of things like for the prazosin and the ketamine, the results look sort of good, but there's a couple of points that we'll talk about potentially tomorrow after you guys look at these articles. When people think about PTSD, here's the other thing too that I'm going to say. So when people think about PTSD, we look at, typically it's caused by witnessing or experiencing some sort of serious traumatic event. The person may have felt a threat to their life or lives of others, around them, loved ones. The person experiences this very intense fear and horror. And of course, with PTSD, a lot of times, the first thing that people think about is like military, is the veterans coming back that have experienced, war. Another thing that's common that I see with PTSD is someone that has been raped or held hostage and things like that. But the other thing that happens, and this is sometimes, and I'm not saying it's with the stellate, but you see the other thing that sometimes happens is that individuals, well, a good example with this is that there was a child who was 5 years old that was given the wrong medication. He got olanzapine, Zyprexa, And so the child was given Zyprexa, um, an adult dose of it, had a few side effects, didn't have any, um, did not have any ESP or any, tardive dyskinesia or anything like that. Basically had just some over sedation, okay, would be the best way that's there. The hospital basically kept him overnight, a little over, well, about a day and a half for observation, but literally by the next morning, everything had pretty much stabilized. The child never was put on a respirator or anything like that, just was overly sedated. And the next thing you know is now, including the child's initial or main treater, is now indicating this child has PTSD. And there's really no basis for that. And what I'm getting at is there is a lot of people that have used PTSD, which have not really been truly diagnosed with PTSD. I dealt with a case. Another case I had was a woman who received, she was supposed to be receiving a vitamin injection of adenosine, or an injection of adenosine, and mistakenly received atropine. So she had the effects of atropine overdose, which included a little bit of hallucinations, a little bit, not really psychosis, but a little bit of excessive activity and so forth. And so she has a person that has diagnosed her with PTSD that has resulted in 4 or 5 years later, they were saying that the individual, that she had developed diabetes as a result of PTSD. So what I'm getting at with this sort of long soliloquy is the fact that PTSD sometimes has been an overused term that has been used to associate with a lot of things, and it's not truly PTSD. We see this in one sense. One of the ways that, and you guys may be approached by this because from a legal standpoint, is they always are looking for a psychologist or psychiatrist to diagnose PTSD. And Jason, you pointed here about a teen diagnosed with PTSD from watching a news story about 9/11. Sometimes what you see is that when you look at all the other things the person has done, is they've done things that are much worse and more scarier and so forth, and are doing those multiple times and not having any issues. And so one of the things that we see is we used to see the term now PTSD thrown out and used sort of willy-nilly, if you will. So it's just that, and that creates some issues with regard to some of these studies where people have tried different remedies, especially things on the internet. So typically with PTSD, what you're going to see clinically, and Eddie, that's a good point, is that the DSM-5 is actually was changed to try to address that. At least it was being, it's one case where DSM-5 was being sort of responsive to things that have come up. But clinically, what you're looking for in these patients, and I think most of you are definitely aware of this, is one thing common with most anxiety disorders is increased autonomic nervous system reactivity. And when we're saying increased autonomic, typically, remember, autonomic is parasympathetic and sympathetic. So when you see increased autonomic activity or reactivity, what you're looking at is you may actually have a increased sympathetic, and that can be by itself, or sometimes it may be increased sympathetic and decreased parasympathetic. So it can be either one, or it can be a combination of the two. So you can get, but the net effect is you're going to see that typically you're going to see more sympathetic nervous system activity. These individuals are hypervigilant. One of the things is they seem to be, you see a lot of times, their eyes darting, their heads maybe checking around, just seem to be constantly looking or be on the lookout. Interestingly, one of the things that we are when, when we're talking about, we're trying to increase, in a sense, hypervigilance with a lot of the younger population now on campuses. We see them, walking around with their heads in their phone, or involved in their electronics and not paying attention to some of the other things. So that's an issue. We often see they're very irritable. They have difficulty sleeping. Sometimes their thoughts of these things are reliving what's caused that. And on other instances, what it is that they are afraid to go to sleep because they're afraid something might happen to them. So, Janelle, that's an interesting thing here, is that when with regard to patients, sometimes do not agree with you, don't agree with your diagnosis and feel like you're taking a lot from them by removing that. So, and Carmen, with yours, I've been involved in some of these active shooter responses, and it's sort of interesting with regard to one of the things that was interesting when we were doing our work, basically a training thing with my CROV class. One of the things that surprised me was a lot of people, when we're in the middle of doing stuff, they had somebody come in and shoot. And one of the things that was interesting is that a lot of people ran toward the gun instead of away the gun, or toward the sound of the gun. But Janelle, you make a good point here. Is when people think they have PTSD, it gives, in some cases, it's an explanation for behavior. It may be an issue of trying to define themselves, and that diagnosis becomes a part of their identity. The other thing too is, Eddie, you make the case too, is that by removing that when it's not there, is that creates a lot of issues. And getting back to Rebecca, that brings up the other point, is the disability issues. Sometimes it's an out from a standpoint. So the issue becomes is that because this term is thrown around so indiscriminately, and we see people. I have seen patients that have this diagnosis, and when you look at their medical records, the diagnosis was simply because the patient said something happened to them, and there's no true diagnosis or diagnostic criteria that has gone through. So there has not been someone like a mental health professional that's been able to go through and make that diagnosis. Someone has just related, the person has been experienced or exposed to one thing which could be upsetting, and that has then been the explanation for a lot of these symptoms. There is a lot of self-diagnosis, and this is something I just talked to my students about the other day, which is when patients come in, a new patient comes in and doesn't have any back medical records, and getting the initial information from them, they will include self-diagnoses of various things, which can include a lot of times mental disorders, which can include PTSD, it can include ADHD. That gets incorporated in their medical records, and it's just like an allergy sometimes when that gets on there. General practitioners a lot of times it's not uncommon that they will list that and be treating the patient with it. So that's a big issue. And you guys are pointing out some very important points with PTSD here, is that basically many times we have an overdiagnosis. And even with that, not only with the overdiagnosis, but a misdiagnosis. And when you've got that, sometimes treatment modalities and so forth get put in there, which can be sometimes, in my opinion, more harmful than actually good. Because one, sometimes the treatment modalities, especially if they're drugs, may have side effects that the person may need it. But the other thing is they may be focused on that aspect of treatment and not actually being treated for the right thing. I have a colleague that I fight with, and he works at the university here, and he just came from the hospital setting, and is very frustrated with regard to dealing with a lot of the students coming in who have made self-diagnosis and the diagnoses. We are dealing with sometimes individuals that may have consensual sex, and then they break up or whatever, and then then becomes rape, and now it's PTSD and all these other things. And then we have things where the PTSD is sort of the default, where that it gets out of them. But interesting, it gets them out of the things they don't want to do, but they also don't want to necessarily to register with disability services to work with that and to follow up with treatment. They just want the diagnosis, but not the treatment. But this sometimes falls a lot, and sometimes parents will put it on kids, especially if there's been a bad divorce or something like that. That's issues that are coming in there. Insomnia, they can't sleep. They sometimes are afraid to go to sleep or stay up because they're worried something's going to happen to them. Sometimes they can't sleep because when they fall asleep, they don't sleep well. Another thing is they have a heightened startle response, so that little things cause them to react, have a much more exaggerated. If you're sitting in and you're sort of not paying attention, somebody drops a book, you may, basically jerk just a little bit because it startled you. But these people, certain stimuli or cues actually make it, they respond much, much more exaggerated with regard to that. So just from what you guys are, telling me on the chat room, and I think, and it's good for people to understand. And Arnold, this is an issue that comes up sometimes, is that we see sometimes in the military and sometimes in the police, fire, and stuff like that, is they don't want those don't want that diagnosis. So there are times when individuals that are trying to diagnose it either are being given misinformation to prevent the diagnosis, or we've even some individuals that may feel like that if they do get a diagnosis of PTSD, that it will make them appear to be more vulnerable, and that's not an image that they want. And sometimes it's not the image of police, fire, or military. So it's something to keep in mind. We see in general, and seeing from the chat, several of you have had some good experience of it, and that's what I've seen with a lot of the people in this particular going through the postgraduate program is PTSD seems to have a lot of experience there. But we do see that people have a reduction in their usual activities. They just sort of lose interest in it. Some individuals sort of have this feeling of numbness or detachment. To me, that sort of the numbness may be sort of a defense mechanism or adaptive mechanism that the body has. But one of the things too is that their feelings seem to be very restricted. That is also I think a protective mechanism. But here's one of the things that we run into, and this makes it sometimes very difficult, is that a lot of individuals, there is that they will start self-medicating. Sometimes they're afraid to seek help, but they may start self-medicating. Sometimes they may go in and give symptoms of something else, but protect in a way themselves from getting the diagnosis of PTSD, so that they can get things like benzodiazepines. But we do see substance abuse can occur as a result of this, and it's usually self-medication. We also see that there are certain situations, stimuli, that may make it worse. And so from that perspective, my slides are jumping here, so it seems to be very sensitive. So what they may try to do is they may try to avoid things, but also sometimes, trying to discover what these stimuli are. Some of it is can be pretty intuitive. So, for example, if someone has been overseas, or, in a military conflict or something like that, and loud noises, explosions, and things like that, most people can identify, but sometimes there's more subtle things that may actually exacerbate those symptoms, other cues. So, in general, what you look for is difficulty in falling asleep or staying asleep. One of the things that we have to be careful about with this thing here, I'm just touching base on. I mean, I'm trying to put in some things of where we got to be careful. Is that the person may actually be pigeonholed into being just having some sleep problems, and so the issue may be that we're just going to give them some sort of sleep medication, typically Ambien, Lunesta, something like that to help them fall asleep. People will self-medicate with this. They may be using over-the-counter things. Kirsten, that's a good point. Is certain dates we forget sometimes about certain dates that may come into play. Anniversaries, birthdays, anniversaries of when they died, things like that. And the other thing is, Carmen, is that sometimes they don't want to go to sleep. And so what they will sometimes do is they will use things like caffeine, they will use stimulants to try to stay awake. And the idea is to stay awake until they just almost collapse, where they just, literally just drop off because they can't stay awake. They're extremely exhausted. And what happens sometimes is they can have panic disorders or panic attacks because in situations where they may be put, where they may sleep or something like that, sometimes where that, a particular place maybe make it very, very difficult because, for example, if they were in a camp where there's some barracks or something like that, that may remind them of being overseas. But again, they have difficulty falling asleep or staying asleep because they may be afraid of nightmares. They may have difficulty falling asleep or staying asleep because they're afraid of something might happen to them. So, and sometimes their sleep hygiene just gets so messed up that what happens is they may stay awake a lot at night. People don't think about this, but they stay awake a lot at night. So what they end up doing during the day is taking a lot of short naps, which means at night it helps them stay awake, but it really is not getting them the good sleep. They can be very irritable. That can be contributed to by the PTSD, but it also can be due to the sleep deprivation. They can have angry outbursts, difficulty in concentrating. So a lot of different things can come into play with these. We considered acute if it's less than 3 months, and we consider it chronic if it's 3 months or more. We do have a delayed episodes of PTSD, which may occur that there's a stress, and then 6 months later, the stress may go. Why would you say, what in your opinions, how could if somebody truly had PTSD, then how could that occur 6 months after the stress? Anybody have an idea about that? One thing may be shock and just dealing with it. Sometimes it's post-deployment. Generally, that's what we see as the deployment. One of the things that can happen is this may be, sort of hidden because of in using military, it may be hidden for a while, or even like if we use something like sexual trauma, rape, or something like that, it may be sort of this facade they put up to sort of stay behind it because they may think they're more vulnerable. Sometimes it gets, as one person puts it, it gets shoved deep in their mind and they're able to block it out. But then what happens is they seem to be doing fine because of this, and then they leave, like post-deployment, they get over here, things sort of relax a little bit, and something triggers it for it to come up there. But realize that a lot of mental diseases, depression and all that a lot of patients, their adaptation, if you will, has been to basically put facades on it. And so they mask the symptoms, avoidance behaviors that can occur. And so what they do is they try to just stay too busy. And the other thing is they try to get too exhausted. And sometimes what happens is if they may try to self-medicate with alcohol or something else. And so basically what happens is with those type of things going on, it's sort of, pushed back, but then it shows up a little bit later. And then Eddie, as you were talking about there, is that, a lot of people, especially, maybe you've got, and they're looking at us, all they're looking about is, let me just, their hope is the PTSD is like, let me just get through this, and I stay busy and so forth. And then when they're post deployment, what happens? They get back here, and there's not enough to keep them busy, in a sense, or then they have time to start thinking about it. And so there's a lot of different reasons for those. Um, um, so that's a big issue that comes into play. So it's one of those things that there's an awful lot that comes into play that makes it difficult. And I think it's also one of the reasons why, we have to be very individualistic when we're treating these patients, because that some things may work on some people and other people, just like different types of therapy will work on one patient and not another. So typically the traumatic events that we see associated with this, obviously war, we've talked about them quite a bit. Another thing is violence and abuse. We see child abuse, rape, domestic violence. That's an issue there. One of the things that I have seen with regard to, as far as this abuse here that's coming into play, is with all these dating apps that are coming up and things like that, there has been some things coming up with regard to just having difficulty determining if it was rape, and then of course to almost validate the rape. One of the issues is that the PTSD gets brought up. One of the things that I've dealt with a few cases here, the hookup apps is a big issue. But here's the thing that I've dealt with 3 of these cases in the last year. An individual, it's again one of these more of these hookup apps or dating sites. 2 individuals meet, but one of the things that happens is, in particular, is heavy alcohol drinking, and one of the issues that occurs is someone experiences experiences blackouts or brownouts, and so to them, to the other person, they may appear sober or being consensual, but this person then has a blackout or brownout and then thinks they've been raped. And so I've had 3 different cases dealing with this, and all involved primarily alcohol. There was the allegations of GHB in one case, but when we put everything together, coupled with cameras, camera videos of different things, it wasn't. And so that's a cur. So that's an issue that has to be sorted out. The trauma events, Janelle, that you mentioned, sometimes in correctional, traumatic events or trauma, you can call them trauma events, traumatic events that occur sometimes in correctional settings, is a concern that's come up there. Terrorism, we've had, a number of we've seen over the past few years, several of the active shooting issues that have come up. And natural disasters. I mean, think about, I think several of you may have been involved with some of the relief from Katrina and some of the others, some of the other hurricane issues, and then you got earthquakes and things like that. And then also, the thing is, we've had some motor vehicle accidents. We're traveling faster, and, I was coming back from a conference and found out that a friend of my daughter's, she and her husband were riding on a motorcycle accident and had some pretty severe, ended up, truck pulled in front of them and they ended up T-boning the truck. So when you're dealing with a semi-truck versus a motorcycle, needless to say, the truck's going to win. And the husband is 4 months into rehab. It's going to be 4 months into rehab minimal. So we see a lot more of these issues there, but I think, between natural disasters, terrorism, and then some of this violence and abuse issues, we see a lot of that. That's right. Physics don't lie. There's a given as to what is going to win in that thing. So, one of the things is that a lot of people, once they've experienced some of these traumatic events, there's this relief that they lived through it and survived. That's a big issue. But then after that initial relief, one of the things that that happens is they start, after that relief starts to subside, it's sort of like they take a deep breath, then they start thinking about. So you start seeing stress, you may see fear, what's going to happen? This, I could have died. And if I'd have died, I mean, people after a heart attack sometimes under this, it's like, if I died, what would happen to, my family and all this other stuff? Or, and sometimes anger from a standpoint, I've tried to take care of myself, and here's somebody that's not taking care of themselves. Or, just like with regard to the truck issue, is first of all, is there's stress now that when I go, this couple of those on the motorcycle, stress when they get on the road to drive again. There's that stress there. There's the fear. What if this happens again? What if I get hit again? It could be worse. The anger of, here's a truck, that pulled out in front of them, and they can't, and this just keeps cycling over and over, and they just can't stop thinking about it. I had a student the weekend of Labor Day. This is Survivor's Guild is a good thing there. So here's one of my pharmacy students sends me an email, says, I'm not going to be able to come to class, and I probably won't be there. We had 2 classes in that. We met for 2 times during this week. And she said, I am most likely not going to be at both classes. So what happened on Labor Day weekend, she was at her fiance's house, and her future father-in-law fell out in the garage, had a heart attack. And so she was there, and she'd been trained in CPR, and she started, she tried to do CPR, but didn't save him. He ended up dying. So I've had one conversation with her, a couple of conversations with her. And one of the things that the initial conversation was starting out just like, how are you feeling about that? And one of her things is that, I keep thinking, what could I have done differently? And I did talk to her about that situation with regard to that she should go talk to someone, and, a counselor and so forth like that, but she's going through that. So Arnold, I just saw what you had, and sorry you had that there. And, but it's not an uncommon thing that occurs back. So, I think, and Arnold, I really appreciate you sharing that with us, because it's one of the things is that it's important for us to realize that even though we understand all of this, because we know the physiology, we know this is going to happen. We've dealt with patients that have had this and so forth, and given them. But knowing all of that is just recognizing the vulnerability that we have there too, puts us into touch with the patients that you guys are dealing with. So with all the knowledge that you have, like you have, Arnold, the issue is the recognition that this came back. I think that's going to be an important thing. We're glad that you survived, and we're sorry you're having to go through that. But I think it gives you, one of the things you need to look for is that basically that has increased your skill set. You have an understanding of someone with PTSD that many of us don't necessarily have. There's different things that when people, experience these things, and then you actually experience it yourself, there is an insight that is very, very special. And so I think, I'm sorry you're going through it, and we're glad you survived. But on the other hand, you have an insight for your patients about dealing with that and so forth, that is going to be extremely important, and you'll be able to use. So, but we're glad you're with us, and glad you're doing well. So one of the things is that these experiences are normal to everybody has this. I mean, we go through stress, fear, and anger anytime we have some sort of traumatic event. When my daughter passed away, there was the stress of losing her. There was some anger, there was some fear, and so forth. But so these are normal things. But what you see over times is that it basically, in one sense, I tell people this stress reactions in one sense. You hope it subsides, but on the other hand, part of our survival is that it's going to, um, um, part of our survival is going to, we're still going to remember it. Okay. The biggest thing is when it just gets back to where that the patients can't stop thinking about it. So, Arnold, using you as an example here, is the point is that in many ways you were controlling it and dealing with it, but on the other hand, you recognize that some of the stuff came back, and the issues that occur. I mean, heart attacks in particular, is because you think about that's something that humans can have. Even people in their 50s can have heart attacks, and the issue becomes is that is um, um, they're very unpredictable, and from that standpoint. But on the other hand, it's hard to put it out of your mind, because even just like you get a little bit winded or a little bit, the little pain in your chest, that's the first thing you start thinking about. Am I having another heart attack? So, the PTSD patients, what happens is they can suppress it, but ultimately they can't stop thinking about the event. It just keeps, coming back and coming back with regard to that. One of the things that we find is that, and these are concerns we have with PTSD, is, let's see, let me look at Kirsten's comment here. So again, yeah, we've learned from that. So that's great, Kirsten, from a standpoint. Glad you're, that's coming in here. But, one of the things that we see is that, and as Eddie said, insomnia is a very common thing. But one of the things with PTSD we have to be careful about is we do see an increased risk for compulsive behavior and suicide. So that's a concern. It is one of the things that we see. We also see there is the comorbid conditions, depression, substance abuse, insomnia. But with depression and substance abuse, one of the big things we worry about here is, again, that sets us up for even more suicide. And with substance abuse, the issue is being compulsive with regard to substance abuse is maybe someone is not planning on doing suicide, but the compulsive behavior with substance abuse can put them at risk, can put their family and friends at risk. We've had patients, we've had students that basically have a compulsive behavior, just wanted to try heroin or something like that, and gets bad heroin, gets fentanyl instead. So it's a big concern and a major concern with what we're dealing with. We do see patients experiencing sexual abuse. Some people think they're at a higher risk for suicide. One of the reasons is because they're ashamed. That's a big issue. But one of the things that we see, these last 2 points, and we'll cover these, and then we're going to take our break this afternoon, our first break this afternoon, is a lot of people that don't get medications is because the physicians don't make recommendations for meds. Some physicians are not aware of what medications. We also see that from a standpoint of this is whether if a general practitioner, whether they can manage or even diagnose PTSD, not just taking a diagnosis that the patient says, oh, I have PTSD. But the point becomes is, can physicians, manage these individuals? And the other thing is that what they often, I will say, is that many times what physicians do recommend is meds for particular symptoms. So they're not treating the PTSD. So the person, insomnia is a big issue. So they may just treat the insomnia, give them a prescription for Ambien. Maybe depression seems to be the big issue. They'll just do that. I have found when substance abuse is a comorbid issue, sometimes physicians do not know how to treat it, so they don't treat it or don't address it or try to refer them. So that's an issue there. Then the last point is that we do know that treatment is best done with a combination of non-pharmacological and pharmacological modalities, which is pretty true. And Arnold, you've given us, a great thing here is that, you're talking about how this is coming up with regard to, how the heart attack occurred. And then if you look at, Eddie, what you mentioned there's a combination of meds, and we're seeing SSRIs and prazosin. I'll give you a paper about ketamine this afternoon to read tonight to look at it, and we'll talk about that. So one of the problems is again, I think there's a few problems. I think there is the question of whether a true diagnosis is made. Two is, I think that a lot of physicians are aware somewhat of PTSD, but I'm not sure they know how to treat it. And what they do is treat symptoms of it. And then the third thing about it is that basically we do know that, physicians are going to be, a good physician most likely would refer the person to a psychiatrist or psychologist to deal with the non-pharmacological modalities. And if that's the case, then basically those people could do the medications. But one of the things would be is that you just treating the symptoms. I can give you something to sleep, but that doesn't help with the PTSD. And so there's other things that come into play there. So those are some of the big things that we deal with PTSD is whether it's a true diagnosis, the overdiagnosing, which makes it difficult sometimes to determine how modalities work, because we have people that may be overdiagnosed with it that really don't have it and are saying, oh, this works. So let's take our break. Let's come back at 10 after the hour. And what we will do is that we'll talk a little bit about the neurobiology of it. Arnold, you mentioned about immersion therapy. I know of one person that has done it, and I don't think it was for PTSD, but found that that it was very therapeutic. I know another person that tried it, and it sort of freaked them out. They did not like the loss of control, if you will. But I've heard some strong proponents of it too. So from that standpoint. So anybody else have any experience with that before we break? And with regard to using the videos of the combat, I think the aspect of it is to when we talk about the neurobiology, one of the things is to sort of understand the signals and how to process them. And the immersion therapy, I think, sort of negates or helps on one extent there. So, and Eddie, thanks for that reference there, for that resource, the ptsd.va.gov. Okay, so guys, let's take our break, and I'll see you guys at 10 after the hour. Okay, there we go.
Okay, doctor.
Okay, and we'll do that at the end of the day. So probably we'll plan on doing the quiz probably at about 3:30, 3:40, and that'll be the last thing. And I'll be sending you a couple other papers for the students too. So guys, let's pick it back on here, and we're going to talk about the neurobiology of the PTSD. And so here's what has been suggested from a standpoint is that, and this goes back to a little bit about the fear response we talked about earlier. So what happens is that when someone's exposed to trauma or this excessive fear, that's going to activate the amygdala. Okay, so the amygdala then is basically will activate the other brain regions, and that includes the hypothalamus, which is going to give us the connection to the autonomic nervous system, the locus coeruleus, which is noradrenergic area, the periaqueductal gray areas. These are some other area brain structures that basically then get activated by the amygdala. And what that does is these structures in particular are going to send signals to activate the autonomic nervous system, and also is going to activate the endocrine systems. And that's going to, those account for the peripheral or clinical manifestations that we see with these particular, with this particular situation here. Now, the orbitofrontal cortex normally is going to inhibit activation of the amygdala. So what this normally is going to do is it sort of overrides the amygdala. And so when we see a fear of trauma, the orbitofrontal cortex basically will suppress that somewhat. But in PTSD, what happens is that this ability of the orbitofrontal cortex to impair or to inhibit the amygdala is impaired. So what we have is, think of it as the brakes are not there, that there's normally, when you see something, the amygdala starts reacting. We refer to that sometimes sort of like the reptilian or the crocodilian type response. And so, but the orbitofrontal cortex typically suppresses that, okay? So what we find is that seems to be one area of impairment in PTSD. So we're not able to put the brakes on. We also know the hippocampus, which is going to be involved in long-term memory, also can help modulate that activation of the amygdala. So what we end up seeing here is, this is sort of a schematic, and is basically that when someone is exposed, starting at here, is either exposed to or has a cue which makes them remember what was the fear or trauma, is it sets up this cycle here. What this cycle does is basically we see a reduction in serotonin that may account for some of the depression. The norepinephrine levels tend to go up, and when the norepinephrine levels go up, that can account for some of the aggressive, irritable behaviors. Some patients talk about their thoughts are racing through them and everything like that. And so that's the racy head. The other thing that can happen is this can also come over here and act on the adrenal gland to cause adrenal fatigue, and that can lead to depression. So what we find is we start seeing when this norepinephrine goes up, we'll see increase in these various factors, except for BDNF, which goes down. That basically will interfere or affect the hippocampus. And as this system goes around, what you develop is that you're getting more cortisol release, you're getting less GABA in the amygdala, and you develop this chronic anxiety. The net effect is basically you start responding because your system that normally puts the brakes on isn't there. Now, I'm not asking you to memorize or to learn this system, because it's just is one thing that sets up. What I wanted you to be aware of is that there's sort of a cycle that can set up, and that is what creates a problem. And so every time that the person is reminded or exposed to the cue that caused the initial thing, is that leads to, or can lead to, just this chronic anxiety developing. So it's one of those things which we want to try to interrupt that signal there. We have some data. For example, they've done PET scans. A lot of the research has been done. Let me just ask you this. Most of the research that has been done, well, I've got it in the slide here, so you don't get, most of the research on PTSD has been done either on male combat veterans or on women survivors of childhood sexual abuse. That's been most of our early work that has been reported has been on those two populations there. We are getting data from other individuals that, other demographics, which is expanding what we think. But what they've done is, like, for example, they've shown veterans that have PTSD when they were shown the combat movies. Basically, there was increased activity in their amygdala. Okay, so that was sort of showing or demonstrating that the amygdala was involved there. They've done MRI studies, both of combat veterans and survivors of childhood sexual abuse, and they see that their hippocampal volumes are decreased. So we are seeing some scans that are this providing data, which is strongly suggesting that the this pathway with the amygdala and so forth is involved there. So so again, we're getting some data, and actually some of these new SPECT scans and stuff that are coming out, we're seeing should provide some additional good information. Now, when you look at prognosis, one of the things that you see is that it varies from patient to patient, okay? What do you think causes this great variability from patient to patient? I mean, with any modality, I mean, any disease treatment, what we find is there is a big difference. And so, one of the things is that resilience, support, that's going to vary, genetic changes, protective factors, treat modality, patient involvement. These are all things that come into play that basically can affect the patient prognosis. But again, going back to what we said earlier, is that one of the issues that comes into play is that, if you've got the proper diagnosis, and we do see better prognosis when there is, probably combination modalities. Now, this next statement is that I've made here is that many patients with appropriate therapy will recover completely or near completely. When you look at the research, this is what people like to say. And the key underlying point here really comes into play where it says with appropriate therapy. And when we say with appropriate therapy, that includes that they are getting the right drugs and the right non-pharmacological modalities. But it also is going to involve the situation of looking at the comorbidities and being able to address those. That's going to be another issue there. And we do see that people can have, they may have relapses that come into play here. But, we do see that some patients really never really recover. People have estimated some of these statistics are hard to get because we lose follow-up on some of these patients, okay? But it's estimated about 33% may never recover. And the reasons for that could be many of the ones that you've got there. In fact, one of the things that happens sometimes, especially military issues and sometimes with, sexual abuse, is individuals may be very weary or very leery of, or they have some trust issues with regard to, the treatment and so forth. The willingness to participate includes with, are they capable of doing it? Do they want to do it? Do they trust it? Those are all issues that come into play. We see that the duration of symptoms, and I think there's more variability, although, the literature will say something, Eddie, you made a good point, avoidance is the linchpin, is basically a lot of it is, I've talked to some judges, and here's an issue that comes into play is that somebody gets, that's exposed to this, but may be involved in a crime or something like that, or they get taken out, maybe a foster home or anything, but they may then be returned. Like we've had some children that were taken and put in foster homes till things were, and then the grandparents came down and were going to take them. But the problem is the children went right back into the neighborhood and so forth. And so we see a lot of issues there. The symptoms, I think, vary more than this. The average duration of symptoms, I think there's a wide range here, is that basically they can be 36 months if receiving treatment, 64 months if no treatment. But I think that, again, there's a wide variability here. I think that it's one of those things which it's like mortality statistics. My daughter's oncologist used this term, and she said 5-year mortality. She says, and she was one of my students, and I think she was bright to see this. She said, I never tell my patients 5-year mortality statistics. She said, because they vary so much. She said, what we use 5-year mortality statistics for is for funding. is but there's such a wide variability there. And I think the same thing is with PTSD, is that I think that there is potentially good prognosis. But if we, look at, as Arnold has shared with us, the issue becomes is that sometimes the trigger comes back. And when the trigger comes back, you may not know or expect it for that trigger to come back. The question becomes is being able to adjust and handle it. And that is, going to be a real important thing there with treating these patients. Having them understand and having their support groups understand is going to be key. It's going to be another issue there. All right. What we do see, and some of these are pretty much common sense, is people that have a good prognosis is one, rapid initiation and engagement. So not only do we start the treatment, but they engage with the treatment. Those individuals' prognosis is usually better. Avoiding retrauma. Many times that is most people would say, well, that's a given. You don't want to put them back in that situation. But I think you guys that have worked with people with PTSD see sometimes that that retrauma can still reoccur. If they don't have any premorbid functions, there may be other things that are going on that may have that may make them more susceptible to things. Let's see. Janelle, you asked about the thoughts on vicarious trauma and intergenerational trauma. Janelle, that is a good question there from a standpoint of on mental health. I do think that it probably does impact it from a standpoint of the situation as to people that are treating. One of the things that happens is that in addressing these type of issues, one of the issues becomes is you got to think about where these people are getting treatment and whether these individuals are actually recognizing that this may have an impact. I haven't read in detail Rachel's work. Eddie, do you know what she's found in general? I was looking at epigenetic changes. That may be something we might to pull up there from and maybe I can pull some of that up tonight and take a look at it, go into a little bit more detail. I do see in general, I think there's been large strides in looking at a lot of these components that are there that we haven't used in the past. But I think one of the things that sometimes is that systems that may be more rigid, sometimes like our VA and things like that, may sometimes be hesitant, or the clinicians may be hesitant to address some of those issues there. But Rachel, Janelle, I'll get some more information on that, and we may talk about that in more there. The other thing too is that with some of the genetic stuff that we're getting is going to be that came across at Zubiquity yesterday when they were talking about looking at some of the genetic, both in human and in animals. It was really amazing about some information that was emerging with there. The other thing that we find is, patients that don't have any comorbid psychiatric disorders and are not, substance abuse users, then those issues all you would anticipate that there would be a better prognosis in those individuals. But ultimately, yes, we see that, but I think even with some of these other things, like, for example, comorbid, is the ability for rapid initiation engagement of treatment, I think is a key point with regard to most situations. All right, so we'll have a little bit more discussion on PTSD, because one of the other things that we will be addressing, starting probably tomorrow, is that we'll be going back through these situations, and this will be a good place for us to address a couple of these things, like what you've got, Janelle, and things, but we'll be going through each of these different anxiety disorders and talking about the specific treatment modalities there. Okay, now acute stress disorder, very similar to PTSD, and typically occurs with 1 month after highly traumatic, event. And typically, what they're going to see is, three symptoms, three dissociative symptoms, either during or after the event. One is the person sort of is a sense of numbing. They just sort of, that's sort of a protectment. A lot of times there's this detachment or absence of emotional responsiveness to the event. They sort of become very focused with regard to not looking or not aware of their surroundings. And then they have this sense of unreality that's related to the environment. And a lot of times they have a loss of memory. They don't remember things. So this one is a condition that we see. We do have one of the things which is called acute distress syndrome, which is different than acute stress. The acute stress disorder is more like the PTSD, but the acute distress syndrome is basically where that something's, they get distressed, and basically they have some impairment in some important area of functioning. So their social or occupational or other areas, they withdraw a little bit. Typically this is going to resolve a lot quicker than some of the other conditions. This we are seeing quite a bit of substance-induced anxiety disorder because we've seen an increase in substance abuse. Typically what we find is that the person pretty much develops symptoms such as anxiety, panic attacks, maybe obsessions and compulsions. These typically are going to occur within a month of using a substance or with stopping it. Probably the stopping thing is basically maybe some withdrawal symptoms there. And typically this one is going to be associated, or we're going to be able to relate this to them using a particular substance. And when I'm saying substance, pretty much drug abuse or alcohol. And again, right now, what I'm trying to do is just go through an overview of these different anxiety disorders so that we can just sort of talk about them. So phobias have been around for a long time. Used to, we called them social phobias. Now we call it social anxiety disorder, SAD, or we may refer to it either as a specific phobia. And what we see with this is basically that the person is has a fear of something. It can be an object, it can be a particular situation, it can be an activity. So, for example, they could have a fear of water. That would be an object. They could have a fear situation, which may be, having to, to perform something, or a particular activity, maybe flying or something like that. But the problem here is that what we see is, again, as we talked about fears with phobia, is that the fear is really somewhat uncontrollable, and it's almost irrational. As we talked about, is we talked about roaches or an insect or something like that. It's that the person just thinks the worst is going to happen, and this becomes very disruptive because what they're going to do is try to avoid it, and sometimes they actually can hurt themselves trying to get away from whatever it is there. So the reality of it is, the thoughts or the fear is way out of proportion to the actual danger that's posed. So, for example, the fear of a roach it could be that it's going to hurt me. And we don't know of roaches that, have hurt anybody. It could be that, for example, that someone could be afraid of needles. And the issue is, yes, if you get stuck by a needle, it does hurt a little bit, but on the other hand, it's not going to be this life-threatening, pain that you would anticipate. So probably, if we start looking at social anxiety disorder, when people get put in unfamiliar situations, or they feel like they're being scrutinized, basically looked at quite a bit, what they do is they may feel humiliated, or they try to avoid the situation. So, for example, people going to a social activity, going to a dance, is someone may be afraid to go to that dance, get very anxious over it because they can't dance. They're afraid people will laugh at them, that it will embarrass them. Sometimes relationships, sometimes people, they develop a lot of anxiety disorder because of, going to meet your significant other's in-laws or something like that. So what people do is that they try to avoid these. There's a lot of avoidance. They get sick a lot. They make up excuses for not going. They do a lot of things that just prevent them from doing these things. And so, but if these individuals get put into this situation, we've all been probably had some degree of, or can identify with this, is that the first time you ever talked at a meeting, a national meeting or a regional meeting or in front of somebody, is a lot of people are going to feel uncomfortable. But some people with social anxiety disorder, that may be much, much better. I use the example of a friend of mine, who played the organ, is that interestingly, she liked playing the organ in front of church and everything like that, but got extremely anxious, almost to the extent of panic attacks. Like I said, she had GI problems, but we do see people that will go into a panic attack. I've had students that when they have been called on in class have literally gone into a panic attack. And the biggest thing is that these do differ. This is not somebody being shy. And it's not somebody that's having performance anxiety. When, the first time I gave a lecture to a class, I was nervous. I was afraid that somebody was going to ask me something I didn't know. I was afraid that I was going to get up there and not be able to think about, to think about what I wanted to say, or that I would get tripped up or whatever. And the social anxiety disorder is much worse. I mean, it's much greater, much more severity. It's pervasive in everything they do, and it creates a lot of distress and even impairment. So when I got up to give my first lecture, I was nervous. There was a concern about whether the students would like me, concern whether I would do a good job, all these other different things there. But this is much, much greater than that. We see a lot of people with social anxiety disorder often have anxiety, especially in the presence of authority figures. This could be anything from a police officer to, your boss. They're afraid of being embarrassed. Sometimes they get up there and they're afraid that they might wet their pants, that they may, sweat so much, or that somebody is going to evaluate them in a very negative way. So these are things that that come into play with the social anxiety disorder. We do see a social phobia, which occurs quite frequently in the adolescent teen years, between the ages 11 and 19. Sometimes when they're younger than 10, they just clam up. They have mutism. So they may not talk in front of, certain people. Rarely do we see this after the age of 25, and we typically see it in females more than males, and that's just a social phobia. This can also be classified as SAD. What we have here is that we get a specific traumatic or humiliating social event. And basically what we see is that sort of seems to be the onset. And then it starts getting worse, okay? We're seeing probably more publicity of this with the issue of people being concerned about bullying and being rejected and so forth. And what happens is these negative memories of what happened in the past, basically they start worrying about what if it happens again and it's going to be worse. And then specific phobias, generally there's a specific thing that they're afraid of. And we see there it's usually either animals, can be natural environment, can be blood injection or an injury, could be a situation, could be something other. And so what happens is that people, when they're exposed to whatever this is, this object or situation, puts them in an avoidance situation, which is really more than is actually necessary. That's why we call it maladaptive. And they have a pretty severe anxiety reaction. So with the phobias, I'm not going to ask you this, but I just put this slide in here. So I'm not going to be asking you about, prevalence of different phobias, but just, normal anxieties, just a list of these things. From a standpoint, we talked about snakes. A lot of people are afraid of snakes. People being up in high places, altitudes, high exposed places. Like, for example, I'm not afraid to fly in a plane, as I said before, but if I had to climb a telephone pole, I would be nervous, okay? There's people afraid of mice. There's people afraid of flying on airplanes. We've probably gone into those. People being claustrophobic, afraid of being closed into some sort of small, tight space. Spiders and bugs are a very common phobia. Thunder and lightning. Being alone in a house or being alone in any building. People are afraid of dogs. Sometimes on dogs in particular, I've run into that there's some cultural issues. For example, I had a Nigerian student that there was that when he grew up, the village that he grew up in, the wild dogs around it, they were very afraid of those, and so his fear was based upon those situations. Being in a crowd of people afraid of cats, so there's a lot of different phobias, and some people, are actually afraid of it. Like this chart here says, people are afraid of it. There's people that it bothers them. And then there's people that just aren't, we see people that aren't afraid. And you always are going to find somebody that, for example, would, easily climb up a tower and not have a problem with it. But this was just really to just give you sort of some ideas of some common phobias, and you've probably seen those or heard of those anyway. I did throw this slide in just because I thought it was interesting, is because these are some unusual phobias. Aerophobia, the fear of swallowing air. Arachobutyrophobia. Butyrophobia is the fear of peanut butter sticking to the roof of your mouth. The bogeyphobia is fear of the boogeyman, boogeyphobia. And I love the next one is hippopotamonstrossus equipopedia is a fear of long words. Trichopathophobia is the fear of hair. And xanthophobia is the fear of the color yellow. So there are a lot of different phobias. I'm just curious to how many people, that's what I was just getting at, Carmen, is I'd be very curious how many people, would have these type of things. I mean, you think of something like, I can sort of, if I was a public speaker, I could potentially, or if I was, in the air, I could see somebody like that have a fear of long words. I know that there are some people that just don't like the touch of hair and so forth, and I could see where that could be there, but I don't see how somebody could fear the color yellow. There's just some, and the fear of peanut butter sticking to the roof of my mouth, that was one that just sort of, I don't know, I'm just sitting there going, peanut butter sticks to the top of, I give that to my dogs and watch them for, 5 minutes while they're trying to get it off of them. So So, it's really interesting. And if you really don't like somebody or really want to get under their skin, you can be like Janelle. Just you knew somebody was xanthophobic, is basically just wear yellow every day, or whatever their fear was. But anyway, this slide was just really more of just some unusual phobias as I was writing this lecture I came up on, and so I just put it on there, which I just thought was interesting. Now, with the phobias, what we do see is there seems to be a overactivity of the noradrenergic component. This is suggested primarily by the symptoms that we see that seem to be mediated. So one thing is, a lot of people, when they're afraid, they tremor, they shake. And we know that a lot of times is produced by excessive noradrenergic activity. Their heart rate goes up. That's tachycardia. We know that's due to norepinephrine. The blushing, the noradrenergic centrally could potentially cause some blushing. And one of the things that came about was because people thought this was noradrenergic. What they thought was, well, we can use this we can use beta blockers. And since it's noradrenergic, it must be acting through the alpha and beta receptor, primarily the beta, for example, with the tachycardia. So people have used beta blockers for treating phobias a little bit. Mainly what the beta blockers will do is they will slow the heart rate down, which is probably one of the most bothersome effects. The tremors sometimes are associated that the beta blockers may actually help that a little bit, but the reality of it is pretty much when we use beta blockers for these phobias, what we're really doing is primarily slowing down the heart rate. That's basically what that comes down to. We do see that these can be precipitated by a specific event. A panic attack can precipitate a phobia. But we also see there's people that there doesn't seem to be any, like the color yellow, somebody just seems to be afraid of yellow and we don't know what the precipitating event was or why they would be, like that. So, but we do see that the phobias frequently, people that have a lot of other anxiety disorders frequently will have phobias that will be part of that. And how much this affects the individual really is going to vary. And that's really one of the issues is some people we just live with that they have a phobia. So if somebody has a fear of heights, we just, we know they're not going to go get a job that's going to be, climbing radio satellite towers. We know that they're going to, when they go places, that they're going to try to avoid being up on heights. So really, most people with phobias are able to function okay. They just sort of avoid the situations. But the really problem is when it becomes, like, for example, if somebody develops agoraphobia or fear of crowds, this may become more of an issue because somebody that may have a fear of crowds what is a crowd? A crowd to them may be 4 or 5 people. I mean, some people, a crowd may be hundreds of people. But the point becomes is if like they are afraid of, if they're claustrophobic, they may not want to get in an elevator. And so they may take stairs up. Now that could be an issue if somebody had specifically some real issues, health issues that prevented them from taking stairs up. So how much dysfunction occurs really will vary between individuals and the specific phobia. When we look through the different models, and again, one of the reasons we try to come up with the mechanisms or model of it is because it gives us sometimes a substrate or a means of treating or maybe developing treatment. So most people think of phobias, they think that explain it by a behavioral model. And they feel like that these phobias are learned through conditioning and modeling, that these phobias develop. But again, some people develop phobias and we don't really know what's precipitated that. So that's why we really haven't established that all phobias occur that. We may see that somebody is exposed to something, has a bad experience, or every time they're exposed to it, they may develop a phobia with that. But, we all have a natural fear of falling. And sometimes fear of heights is where that it's not like we would get up there and fall great distances and learn that that's going to hurt us. So the exact mechanism of phobias has still been up in the air a little bit. We say that, one model is behavioral, that you learn it, is that you've learned to have these fears. Another one is called an evolutionary or biological, which means that you're predisposed, that your genetic makeup basically sets you up there, and it's probably associated with a, quote, faulty brain chemistry or pathway. And another model is cognitive, which basically says it's just maladaptive thinking. So the exact mechanism of phobias we don't really know, and there's been several that's been put forward to try to explain it. So this is a good place to take our break. This will be our last break of the afternoon. Let's come back at 5 after the hour. We are going to, Aiden's going to take the attendance poll, but we're going to go back over the neuroanatomy of fear and anxiety in preparation for start talking about the different treatment modes. So we're going to spend some time with that this afternoon. Okay. All right. And I will see you guys at 5 after the hour. When we're looking at, so we talked about this a little bit this morning. So let's go back over it a little bit, because this is going to serve as sort of the substrate with regard to our pharmacology that we're going to go into in much more detail tomorrow. So what we find is that basically the amygdala is going to be responsible for basically acquiring for the acquisition and expression of fear conditioning. Okay, we have 3 nuclei that's going to be involved here. We have the basal amygdala, which I'm going to abbreviate as BA. We have the lateral amygdala, which is LA. And then we have the central nuclei, which is CA, which stands for central amygdala. So what happens is that we get the sensory stimuli that comes in from the thalamus. That gets transmitted to the lateral amygdala. And then that goes to the central nuclei. So this is referred to as the short loop pathway. We also see is that the basal amygdala connects to these 2 other nuclei there, both the lateral and the central nuclei. So here's what's going to happen here is we also get some signals that go to the lateral amygdala from the sensory cortex, from the insula, the prefrontal cortex. So that's the long loop pathway, whereas what I just told you is considered the short loop pathway, which is we're just going from the thalamus to the LA and then to the CA. So we have a long and short pathway that's there, loop, or if you will. So this information is then sent to the brainstem and the hypothalamus, and that's what actually, as I mentioned earlier this today, is that's what actually produces our behavioral responses and also the responses we get with our autonomic nervous system. So one of the things that we do see is this lateral amygdala is going to be, it's an area that's been identified as being responsible for consolidating memory and plasticity, and this comes into play with the fear conditioning. So if we take animal studies and we basically lesion either the lateral amygdala or the central nuclei, that actually disrupts the acquisition of this conditioned fear and long-term fear memory. Okay, if we put a lesion in the BA, basal amygdala, then basically that can also affect fear responses. So what we think happens is there's a potentiation that occurs. On a molecular basis, what happens is that your memory gets consolidated when calcium sort of enters the cells, and that goes through the NMDA receptors. And it also uses voltage-gated calcium channels. If we block these calcium channels, that tends to short circuit the short-term loop, but it doesn't affect the long-term loop. So it only requires the NMDA receptors that are necessary for this pathway to be active. Okay. So when we look at this, if we get, we see that, in animals that have been conditioned, or that basically we've looked at the fear response, and what we see is that those animals have a high expression of these NDMA receptors, specifically in the hippocampus, and that suggests that the hippocampus is involved there too. So what the suggestion of identifying and separating out all of these different things is that basically is, if we either block the NMDA receptors or we block the calcium channels, this may be targets that would impair memory consolidation and would help us to treat those anxiety symptoms. So the situation is that these are some things that look like potential substrates or pharmacological substrates. One of the problems, though, is going to be to get those, get drugs into those areas without any side effects, or with minimal side effects. So as we start talking about this anxiety and fear, you'll see, as I point out tomorrow, we're going to go through information that will talk about how these drugs may interfere with these different cycles here. And sometimes what we're going to find out is some of these drugs that we're going to use may simply be working, in some cases, only on the autonomic component. And on other instances, we may see that some of these drugs are going to be acting up in the brain. Keeping in mind that with all of the drugs that we use, we have to keep in mind, can we get a therapeutic response with a minimal of side effects, or can we get a response in which the patient may be able to tolerate that? It should be in MDA, and I flipped it around. Thanks for catching that. See, I'll just throw that in just to increase your anxiety and to make sure y'all are staying there. So it should be in MDA. All right. Now, we've talked about a bunch of other disorders. Let's go into one of the major ones that we're going to see, which is basically generalized anxiety disorder. And we probably see more pharmacological treatment with regard to this than several of the other than PTSD. We probably see GAD treated more. So one of the ways that this has been described is that there's extreme feeling of anxiety in the absence of any clear cause. Okay, that people just worry. We see, for example, that to diagnose this, what we're going to look at is we're going to look at people that have excessive or ongoing anxiety, and this is going on for at least 6 months, and then it's usually involving a number of things. A lot of people, the problem is that they can't control the worry. On our everyday, many of us, we find that we worry about different things, but we control it. I may get up and decide and worry, like I had to go to Atlanta on Friday. My worry was that I was going to have to deal with traffic. And one of the worries that I was dealing with was that I gave the last talk at 4 to 4:30. And the worry that I had was I was going to be sitting in traffic for 2 to 3 hours to get back home. Okay, that is a worry that was bothersome, but it was not, I didn't have any difficulty in controlling it. It was just resolving myself. This is the way it's going to be. It didn't cause me any significant impairment or distress. Whereas somebody else is getting up every, and is starting to worry to the point that they're even deciding, well, maybe I just won't go. So we start seeing that that it's an excessive worrying when we're talking about generalized anxiety disorder. Typically, we're going to see at least 3 of the symptoms. They're going to be restless. There's going to be restlessness. They're just going to be antsy. They're going to be pacing. They're going to be just constantly moving. Okay. They get fatigued. Now think about this. You're moving around constantly, just over, doing a lot of stuff. That's going to wear you out. Plus, think about this thing. Remember what I talked about this morning, where that people's muscles get tense. And when you're holding that muscle tense, it's going to tire you out. They're going to be irritable because they're focusing, and anything that adds to their worry gets them angry. The muscle tension. Sleep disturbance. For example, somebody that has GAD, they're going to sit there and they're going to be going, as it gets to Friday, yesterday. You know, I'm going to be, if I have GAD, I'm going to be tired. I'm going to be irritable. My muscles are going to be real tight because what I'm going to do is I'm going to start worrying, what about the traffic coming back on Friday is going to be really, really bad. And to the point where I'm just tensed up about it. Every time I even think about Friday is that it's starting to just, it's like I'm just, you know, just um, starting to be one big tight, you know, rubber band that's just pulling in. I can't go to sleep because I am worried about what if it's going to take me 2 to 3 hours, or what if there's a wreck, or what if there's this, or what if, you know, all of those things. And it's just a constant type thing that is going to just be working on. So here's another one of those slides. When I gave you one earlier this morning, this is a little bit different. So what we see is with generalized anxiety disorder, we have low level anxiety about a lot of different things. So for example, low level anxiety could be, I'm worried about the traffic getting back. I'm worried about, you know, what if they don't have my slide set, you know, what if they don't have my slides, or what if my slides have an issue on them, or things like that. What if I, you know, what if I get up there and the audience is different? And so I'm worried about what if I can't find a parking place? So I'm worrying about that. And this has just been going on and it's excessive. And I can't control it. Every time that I sit down and just have a moment, I'm worried about that coming up. So the other thing that happens is this, is starting to worry about my slides jumping all over. Okay, so the other thing that's going to happen, just like with anxiety, you know, generalized anxiety, my sympathetic nervous system is going up. You know, when I start worrying about this, what happened yesterday, you know, about the meeting and all this other stuff, my heart rate goes up, my blood pressure goes up. I'm sitting there so concentrated on it that if somebody comes up and drops a book or taps me on the shoulder, I jump because I am just on edge. That's another term that's used. My muscles feel tight, especially up around my neck, my back muscles. Every time I try to concentrate on something, I start worrying about. So, for example, if I sat down and I said, "Okay, well, I'm gonna work on another lecture," and so I pull up my computer, and now what is I can't concentrate because I'm thinking about, well, you know, did I include all the slides? Do I need to go back in there on the other presentation? And it's just I am distracted. Okay. Can't sleep because I'm worried about it. When I get in my car to go, it's like I'm looking at every little thing that could interfere with traffic. There's some free floating anxiety sometimes is there, but we are seeing these anxiety things which are going to take a toll on us. Our autonomic nervous system, specifically our sympathetic nervous system, is kicking around at high level. That's going to, my muscle tensions are going to, you know, push down on my nerves. It's going to make my back hurt, which now that I'm hurting, it makes me irritable and it makes me start worrying more. Maybe I start worrying that my back and neck's hurt. What if I, you know, what if I get there and I don't feel good? These are just one thing after another, and I just keep adding it to the pot there. So here's what you see though, is people go into primary care physicians all the time, general practitioners, okay? And what you find is that sometimes, okay, I can start worrying about this stuff and then I may even get depressed, okay? So one of the things we see is that primary care physicians, general practitioners, they'll tend to treat the symptoms I have. I'm not sleeping, give me an Ambien. My muscles are tight, my neck, they're hurting, give me a muscle relaxant, give me a benzodiazepine. From a standpoint of maybe I'm getting depressed because, you know, I just really don't want to go over there and all of this other thing. So they give me an antidepressant. So what we find is a lot of general practitioners are treating the symptoms that the patient shows up with because that is easy for them to treat in a sense. They can identify a specific symptom and give a medication for it. It doesn't take that long to do that. Psychiatrists, and some studies have indicated, tend to say that they tend to focus on the major depressive disorders or anxiety disorders subtypes, and those are usually comorbid with this general anxiety disorder. So what we find is a lot of times prescribers are not actually focusing on, you know, the exact thing. And Rebecca, you're exactly right. It is, with general practitioners in particular, it's faster for them to treat a symptom, and the patients think they got help, and the patient, will go to the next thing. So it's not help the anxiety. And in fact, what we find a lot of times is these patients, especially like with muscle tension and things like that, what it does is it relieves it, but it can gradually get worse. And then they show up. So what they do, up the dose. Now, the other thing that we find is sometimes general anxiety disorder may actually represent where that somebody has really not completely recovered from either some other anxiety issue or an affective disorder. Sometimes they refer to these as anxious responders. This is a person that has anxious depression. So what happens is they respond to the antidepressant, but what happens is that they are not as depressed, but it's almost like you sort of up things up where that they have more anxiety, generalized anxiety. They worry about a lot of things, more muscle tension, difficulty sleeping. Those things still are going on, but they're not as depressed. They're, when they were depressed and worrying, they were sort of down and withdrawn. What you find is that they may actually respond, but the depression is not as bad, but the anxiety actually may be worse. So these patients really, as far as their chance of responding is pretty low. We have to, I think one of the reasons that I hate to use the term recovery, although I did on this slide, one of the reasons that we have to focus on things like this is because many times the older data is some of the drugs that we use, we really just focused on one thing. And it was like, which disease do you want us to manage? Us to manage the depression, or do you want us to manage the anxiety? Well, one of the reasons that people managed the depression was because they worried about somebody committing suicide. So, but the other thing too, and this gets back to Rebecca's comment here, is that one of the things that that happens is that the patient gets a lot of meds where we're treating symptoms, and so that's a big concern there. Some of these meds may not be needed if we got to the root of the problem. Typically, general anxiety disorder is going to show up in childhood or adolescence, but we're not limited. It can occur at any age. And we do see it sometimes worsen in the elderly. The elderly population is going to be more and more, because now you start seeing some more issues for them to worry out. It's like, a lot of different things are coming up. Who's going to take care of me? What happens if Social Security runs out? Where am I going to live? Sometimes that anxiety is added to by the caregivers expressing their concerns with how they're going to manage this person. So, but interestingly, actually have a better ability to work in social relationships, but you may see that these individuals may have periods. In other words, maybe the other thing that happens with these individuals, their immune system gets suppressed, so they get sicker more frequently. Things like that. And so that's a big issue there. So that's going on. Are y'all hearing a dog barking in the background, by the way? Because I will tell you, to be perfectly honest, the sound is cutting out. Okay, so I'm going to lean a little closer to the microphone to help with that. But it is actually my dog barking, but I was going to go ahead and blame it on Eddie, who said that his dogs can't understand why he's sitting in front of his computer. So I'll just blame it, since he's already confessed to having the dog there. The dog that you hear barking is Barney, which is the rat terrier. And he has to be sedated a little bit because he is very, very hyper. And he is right now sort of sundowning, in the sense that his meds have run out. He gets a little bit of trazodone every morning, and that seems to do real well. But at about this time of the day, the trazodone wears off. So he is sometimes a little crazy. So, okay, when you look at general anxiety disorder, there have been a lot of different models that have been proposed, been a lot of work in this general area. People have addressed it from their different disciplines. So from a socio-cultural, some people have said is that family or social stress. This can include, for example, a dangerous lifestyle, person working in the military, fire department, police department, environments, race, poverty, aging, all of those things, any of those things basically have resulted in the adaptive process, which is, developed anxiety. So it's the environment that you've got. Biologically, people have tried to associate this with GABA. They also said there may be a genetic component there. With biological, the GABA biochemical dysfunction, especially the GABA pathway, has been one of the main reasons why benzodiazepines and even barbiturates, which we used to use years ago, became popular in the sense. So Big Al has got his, he is sort of chilling out. Big Al doesn't seem to suffer from anxiety too much. So he can sometimes create anxiety for other people, but he's being nice and quiet today, other than the occasional lapping or snoring. So biological becomes we do know there may be a genetic component here that people may, people that have anxiety, maybe, or their family had anxiety, may be prone to that. But biological gives us one of the substrates that we can attack when we are developing drug treatment. The psychodynamic model is basically it's describing that there's subconscious conflicts, that there is realistic anxiety. There's things that occur that really produce anxiety, that people actually experience actual danger or potential harm. They have neurotic anxiety, where the person is maybe overly protective and or may have internalized and can't express their needs. And there's the moral anxiety, which basically is that they experience punishment for their normal expression of needs, but the fact that they need something is bad. And then cognitive is basically, I always like this one, it's sort of like, well, obviously there's some maladaptive thought processes. When we're looking at pharmacological approaches to this, really the biochemical or the biological is the only one we can target. You can sometimes get people that sort of link biological and cognitive. You see those type of things, but some of these others fit more for behavioral therapy modifications versus pharmacological. And let me see where we're at here. Yeah. So we're going to cover OCD mechanisms or OCD, and then this will be our stop for the day. We will have a brief quiz at the end of this, but I want to cover just at least the general consensus here. So OCD is, we do see that about 80% of the patients will have both. They will have obsessive activity as well as compulsive. Only about 20% are either compulsive or obsessive. But one of the things, and we still see it today, is OCD is commonly used to describe meticulous or absorbed behavior. Everybody talks about, oh, I'm OCD. And that's really the incorrect. So sometimes the lay public does not understand specifically what OCD is. It's not addictive behavior. OCD patients actually don't want to perform or actively perform the task, and they don't really receive any pleasure from doing so. Whereas with addictive behavior, that's what we're going to typically see. Typically, we're going to see that these obsessive or compulsions are going to be at least occupying about an hour a day, and they can interfere with normal social and occupational function. Somebody has to stop to do something, or basically can't perform something because it's there. And what we see is the obsessions are more subjective. They're experienced internally, whereas compulsions, these are repetitive behaviors or repetitive mental acts that people do. And then, this next slide is basically just really showing some signs. And probably with regard to obsessions, people can be obsessed with dirt or germs or environmental toxins or whatever. That probably counts for the majority of people. But we often see things like they may be obsessed with something terrible is going to happen. There's going to be a fire, or somebody's going to die, or somebody's going to get real sick. People may have to have everything in a certain order, and everything being symmetrical or being exact. We see religious, we see a number of things that go down. Compulsions, we see probably the biggest one that most people, if you ask what would be a compulsion, most people would say somebody, for example, washing their hands very ritualistically. We see people doing ritualistic or repeating rituals, like going in or out of a door a certain number of times, going up and down, getting up or down from a chair, checking doors to see if they're locked or closed, and things like that. So you see these type of things. These are just some common obsessions and compulsions that we've noticed. We don't really know what the mechanism is. There is a genetic basis, and people have suggested that there is 3 transmitters involved, really 2. One, some people have put forward that it's a dysfunction of serotonin. That's the serotonin hypothesis. Some people have said it's dopamine, and some people, of course, like to say it's a combination of the 2. And that has formed the basis for some of the treatment that's there. So when we look at, and let's just go through these mechanisms. So one theory is that this is linked to serotonin dysfunction. And this has been based upon pharmacological observations or studies. One is that when people are given SSRIs, it seems to be effective. So that's a good thing. So if you give a drug that affects the serotonergic system and it seems to work, that would be, potentially evidence that the drug is interfering with serotonin. There is also, we have found that people have measured cerebral spinal fluid and platelets and found out that that the drugs can induce changes in serotonin levels in those areas. So that suggests that serotonin dysfunction may be here. On the other hand, with dopamine, there's people that said, okay, so serotonin shows some improvements, or the SSRIs show improvement in several patients, but there's about 40% of these patients that appear not to respond. And we do know that giving drugs, things that affect dopamine, can actually induce stereotypical movements. For example, amphetamine and L-Dopa. That would suggest that since you can produce symptoms similar to this, then that would suggest dopamine system was involved. And the idea is that these drugs like amphetamine or L-Dopa actually increase dopamine. So the idea would be that this would, if you increase dopamine, that could cause these particular symptoms. You can also argue that there is a link. I mean, basically, there's movement disorders, and this seems to be associated or happening at the basal ganglia. And the other thing is that some of the older conventional neuroleptics, these are the older phenothiazines, the dopamine 1 antagonists, the old drugs that we used. Basically, when you add those to a patient on the SSRI, we actually saw that seemed to improve. So this also set up for the reason, this last one was, well, maybe it is a combination of dopamine, serotonin. So we don't really know where the primary defect is. We don't know if it's serotonin, dopamine, or it's an imbalance between these two. We know that with some data that we've, with a lot of information we have on the newer antipsychotics, that this balance is important. We do know that serotonin and dopamine, there are anatomical and functional relationships. And we know that there is a decreased serotonergic inhibitory action on dopamine neurons, which basically can lead to increased dopamine function. So we have some indirect evidence that it's probably involving both. Let's see. Yeah. So let's go through the next couple of slides. So here's one of the mechanisms that's suggested. The idea is that your orbital frontal cortex notices something's wrong. Let's use it that something is, you look at your desk and it's not symmetrical. You look at things on your desk. So your orbital frontal cortex goes, that's not right, okay? And so they use the term worry signal. A worry signal is just sent to your thalamus. You're going, something's not right here. So that goes to the thalamus. So the thalamus sends it back to the orbital frontal cortex and says, well, tell me what's wrong about it. So normally what you have is that there is, in between the orbital frontal cortex and the thalamus is the caudate nucleus. And so it sort of prevents the signal coming back from the thalamus. Once it's received it, it keeps it from going back there. So what we see with OCD things is there's something wrong with the caudate. There's a dysfunction there. So what happens is it's like a worry signal. So what is there is, I see that something's not, my desk is not like it should be, send it to the thalamus, send it back to the thalamus, and then it just keeps like a repetitive cycle saying that worry signal, it keeps going. So my thalamus actually becomes very hyperactive, and I form this loop of worry signals that's being sent between the orbital frontal cortex and the thalamus. And what happens is that increases the anxiety. And so what I do to offset it is I do the compulsive behaviors to take care of that anxiety. So what happens here is basically you get a signal that keeps like repetitive signal. And what we do to try to shut that off is we adjust things. We do the obsessive behavior or the compulsive behavior, the compulsive behavior to remove that. So that's been one of the mechanisms that's been suggested that can occur. From a pharmacological standpoint, the idea is, well, let's try to interfere by affecting some of these transmitters. Now, the last, I lied to you because I said I was going to do these two sentences, but I want to just cover, you don't have to really worry about studying these, but no, I'm not going to do that because I thought it was just a couple of slides. So I didn't lie to you. So what we're going to do here is we're going to, Aiden, if you will go ahead and give them the quiz. There's 3 questions on the stuff we've covered this afternoon. And you guys take the quiz. And basically, once you take the quiz, you are done for the evening. We will go over the answers to this in the morning. And then we will pick back up and we will talk about, start talking about a lot of the pharmacology tomorrow. Does anybody have, you're not going to have any readings tonight. You guys get to just relax a little bit and obsess about which readings you should have gotten, okay? I will probably go ahead and send those, get those papers up and send them to you, but we'll probably talk about them. So I'll probably send them to Aiden so they'll be posted. So go and obsess and compulse about what you're supposed to do this afternoon. Try to get your heart rate up, your blood pressure, and your muscles in your neck all tense, okay? So you guys have a great evening. And it's good being back with you guys again. I missed you guys. And I thought you would just go silent on me that first hour because I just didn't see anything with the chat. So, but look forward to talking to you guys in the morning. If there's any questions, send me. So appreciate it, guys. You have a great night.
Awesome. I'm going to keep the poll on for 10 minutes before taking it off.
Okay, now I'm going to go ahead and sign out, and I will see you in the morning.